To the Lupus Foundation of America Chapters Network Let's Talk About It webinar. So each month, our chapter network will present over a specific topic from across the country. And tonight we will be discussing lupus and pain management. My name is Adrienne Kohlenberg, and I am the Patient Services Marketing Manager for the Lone Star chapter in Texas. Before I introduce our speakers, I want to remind you that the information provided in this webinar is for general information and educational purposes only. It is not a substitute for your physician's advice. So the views expressed in this webinar aren't those necessarily of the Lupus Foundation of America. So tonight we have Dr. Pegram and Dr. Michaud presenting over lupus and pain management. So I'm going to go ahead and share my screen so you can see Dr. Pegram's presentation. All right, Dr. Pegram, go ahead.
Great. Well, thank you so very much. I appreciate the opportunity to speak with members here of the Lupus Foundation. It's always exciting to me to participate in events of this great organization. And let me preface my talk this evening for all the mothers out there and wish you all a wonderful, happy Mother's Day, because without you, there would be no us. So we definitely want to wish you all a wonderful upcoming Mother's Day. I also will try to be very brief because I know we have a short schedule, and I definitely want to make sure we have plenty of time for our other distinguished speaker, Dr. Ryan Michaud. So we'll get going here and see if we can get through things in a timely manner. First of all, systemic lupus is a topic that all rheumatologists have a great desire to talk about because it's one of the more frequent diseases that we see, and a disease that in most cases we do very well with in regards to therapy and diagnosis, but sometimes it can be a little tricky. When we go to the next slide. Systemic lupus, I hope that everybody remembers that first term, systemic. We often call lupus just that, lupus, but systemic lupus is a much better term because it is truly a system-wide disease. In fact, lupus patients can have symptoms in just about every organ system in the body. So systemic lupus is an important factor when we describe this disease process. And like almost all autoimmune conditions, it is in fact a true inflammatory condition. Now, when we hear inflammation, most of us think about the standard clinical findings of inflammation, swelling of a joint, redness, tenderness, restricted range of motion, increased warmth to palpation, etc. But when rheumatologists talk about inflammation, what we really are talking about is a cascade of chemical and cellular interactions within the joint space and within the bloodstream. It is inflammation that actually protects us as part of the mechanisms of our immune system that protects us from things that get inside of our body that don't belong there. Bacteria, viruses, other types of foreign proteins, which we call antigens. And without inflammation, we would be quite vulnerable to all of those invading pathogens. But inflammation can also be a bad thing. And systemic lupus is manifest by inflammatory cells infiltrating certain organs. That's why there can be 10 people in a room, all who have systemic lupus, but all who have various symptoms. But based on the fact that these inflammatory cells migrate their way to various organ systems, sometimes to the skin, sometimes to the joints, sometimes to other more significant internal organs. But it is characterized by active and unfortunately often aggressive inflammatory reactions throughout the body. It is actually a failure, though, of that immune protection to recognize self-tissue. Thus, it is an autoimmune disease where the immune system no longer recognizes the patient's own tissue, and thus we have, unfortunately, multi-system illnesses and symptoms. Next slide. It is, again, a multi-system disease. There's not an organ system in the body that's not affected by systemic lupus. And that is also, unfortunately, why it is sometimes difficult to diagnose, because noting that it can occur in the cardiovascular system, in the renal system, in the central nervous system, and also in the articular and bone and joint system, this disease may mimic a host of different conditions. And I'm sure all of you have heard this same comment that it took my doctor 5 years to make my diagnosis of lupus. And that's actually right, because often because of our difficulty in sorting out the other potential diseases that might have similar symptoms, it sometimes is a challenging diagnosis to make. Next slide. But no matter where it is, can we move to the next slide? Uh-oh, we lost our ability to
Sorry,
move.
I'm trying to, but it's not going.
That's not good.
Sorry, everybody.
There we go. Well, it is a disease that is characterized by, again, autoimmune cells. Every aspect of systemic lupus is based on the presence of antibodies. Antibodies are those little Y-shaped proteins that are floating around there on the right. These are proteins that are on a seek out and destroy mission in the bloodstream. And when they detect foreign substances, which is the little ditzel there next to the middle Y called an antigen, that stimulates a host of interactions between chemicals and cells. Those antibodies, once they bind to the foreign protein, the antigen, they will set off a series of events that will either cause the infiltration of cellular elements to enter the area and gobble up the antigen, or it can stimulate a host of chemical reactions that will actually result in the destruction of the antigen. And it's thus the presence and the activity of these antibodies, these proteins that protect us throughout the day. The next slide. But unfortunately, sometimes the antibodies get a little confused in that what happens is that those antibodies down there on the left side of the little cartoon in blue, as we move to the middle portion of that cartoon, you can see that they are attaching or binding themselves to a foreign entity, in this case, a bacterial pathogen. But unfortunately, there may be a few peptides that make up the cell wall of that bacteria that may resemble the same sequence of peptides that make up the cells of the host, meaning the patient. And those antibodies now will attach themselves, as we see on the third panel of that cartoon, they attach themselves to normal host tissue, healthy cells. And the same inflammatory process occurs where these cells now begin to do all the things that they did to the antigen in the previous slide. They try to gobble it up, but gobbling up our own cells is not such a great thing to have happen. And so we thus have the features of an autoimmune disease where basically our own immune system has gone awry. Next slide. With that, we know that there are a number of autoimmune conditions, and one of those most common ones is that of systemic lupus. About 1.5 million Americans have systemic lupus diagnosed at any given year. And about worldwide, we're looking at about 5 to 6 million people diagnosed annually. It generally affects, though, people, unfortunately, at an early stage in life. We often think of arthritic conditions as diseases of the elderly, but nothing could be farther from the truth in patients with autoimmune diseases. Most autoimmune diseases occur during childbearing years. So patients with lupus in their late teens to about their mid 40s are the time of life when we see most of the disease activity. It also has a preference for the specific genders. Women have the disease 9 times more frequently than men, and also ethnicity. It is a disease particularly of African American women. Other ethnic groups of color, including Asian Americans, Native Americans, Hawaiians, Alaskans, even Pacific Islanders, all of them are at increased risk for the development of this disease. So age, gender, and ethnicity are all contributing factors to the development of the disease. It was also thought that maybe it's not all just gender and ethnicity, because African Americans were noted to have the disease more so than Native Africans. But it looks like that data is now a little bit shaky, because it may be just that the ability to detect the disease in Native Africans in their home country was a lot more behind the 8 ball than we have here in the United States. So it may be that we're just able to pick up the disease a lot quicker and earlier in the disease course in the United States versus that in Africa. And mainly it still appears to be a genetic risk. Most of the time, lupus is a very well-controlled disease. And let me reiterate that when we hear the word lupus, it often sends shudders through patients who are newly diagnosed. But 85–90% of patients with lupus have mild disease. They do very well with appropriate therapy, but in about 10–15% of the patients with this disease, it can unfortunately be quite severe and lead to premature death. Next slide. Who gets the disease? As we talked about, women by far 9 times more frequently than men. When men do get lupus, and they certainly can, it often is a little more severe. And the development of internal organ involvement is also much more frequent in men with this disease than women. As we mentioned, it occurs in various ethnic groups. And so again, people of color by far are more likely to develop the disease, but all ethnic groups get it. And then it has no respect for age, although most people do get it between the ages of, again, about 18 or so until the mid 40s. You can develop your first sign of lupus in your 70s, 80s, or 90s. And also, unfortunately, one of the triggers for the development of lupus is changes in hormones. And that means we see this disease rear its ugly, its ugly head, often around the time of childbirth and particularly directly after delivery. Next slide. The symptoms are variable. As I mentioned, it is a multi-system disease. And because of that, we have to be cognizant that we have to look at all particular organ systems when we're evaluating patients with lupus. Yes, doctors still put their hands on people. We still do histories and physicals. And history and physical is really the mainstay of making a diagnosis in lupus. About 75–80% of patients present with constitutional symptoms, fatigue, malaise, low-grade fever, and about another 70–80% often present with joint discomfort, particularly small joints of the wrist and hands. Skin lesions, which are myriad, they're gonna be bumps, they can be flat, they can be bullseye, they can look just like psoriasis, they can be all sorts of varieties, but skin lesions often bring patients in to see the doctor with their initial presentation as well. Internal organ function, the kidney is one of the most vulnerable internal organs in lupus. And unfortunately, when patients have severe renal disease, it is one of the more significant poor prognostic factors. And neurologic conditions, from things as simple as tingling in the fingers, occasional mild headaches, to more severe entities such as seizures and strokes. Next slide. And again, other internal organ involvement, such as the lung, from simple things such as a chronic and non-productive cough to severe inflammatory conditions in the lung that may in fact mimic pneumonia. That's also commonly seen. Next slide. How we make the diagnosis is pertinent because there is no one test, which is very important. There is no one test that allows us to make the diagnosis of lupus. It is based on 11 criteria. You need a minimum of 4 of those criteria. The presence of the anti-nuclear antibody, the infamous ANA, is only one of those criteria. It doesn't matter how high the anti-nuclear antibody is. All it says is that it is one of those necessary criteria. So we need other things with it, some of which are additional laboratory studies that you see down at the bottom of the 11, 9, 10, and 11. These are protein and blood abnormalities, but most of the diagnostic criteria are things that we can see. Certain types of skin rashes, joint pain, particularly small joints of the wrist and hands, ulcers in the mouth, intermittent types of chest pain. So it is very important for the doctor to look at the sum total of the patient's symptoms if this diagnosis is to be rendered accurately. Next slide. Treatment of lupus is also variable, and it's important to note that there is no one drug that treats all of the symptoms of lupus. maybe 10 people in a room with systemic lupus, and all 10 of them are on different modes of therapy. You treat what the lupus is doing. So if the lupus is causing joint discomfort, you give the patient medicines for joint discomfort. If it is causing issues with the skin, you may not need any more than topical agents. If the patient is having issues with the kidney, there are specific drugs for lupus that, again, are more likely to cause improvement in that organ system, and the list goes on and on. So it's important to make the specific diagnosis, and it's important to remember, as I tell patients with lupus almost on a daily basis, is that you treat, again, what the lupus is doing. Not one drug treats them all, but there is one drug which is very important in all patients who have a concrete diagnosis of systemic lupus. Next slide. In those, that one drug that I mentioned is hydroxychloroquine. Yes, it got a bunch of goofy press during the COVID initiation of the COVID vaccine protocols, but hydroxychloroquine by far is probably the safest drug we use in any autoimmune condition. It is very safe. And data since late 1990s to about the early 2000s have shown unequivocally in very large studies that if you have a patient who has documented systemic lupus, that they should be on hydroxychloroquine full stop. There is no, unless there is a true medical reason for them not to be, they should be on that drug. Why? Is because not only does it decrease frequency and severity of flares, most importantly, the data shows unequivocally that patients with systemic lupus on hydroxychloroquine, when compared to patients with systemic lupus who are not, the patients with systemic lupus on hydroxychloroquine literally live longer. So it is important that the diagnosis is a certain diagnosis and that also they get on that drug as soon as possible. Next slide. Also, remember, you treat what it's doing. So a number of other drugs that most of you are familiar with, simple things such as anti-inflammatory agents, steroids, cortisone, or glucocorticoid, names for the same substance. Remember, they are always adjuncts. They are never, ever the basis of therapy. They are only to settle down disease burden until other more powerful and long-term drugs can take effect, some of which are noted below that, the antimalarials. There have been only one new drug that has come on the market in 60 years, specifically for the treatment of lupus, and that is that noted in number 5, that is belimumab or Benlysta, which is a biologic agent that is for moderate to severe disease. But for people who have severe internal organ involvement, it is not severe, it is not strong enough to attend to that patient population. And so those immunosuppressant products such as azathioprine, mycophenolate, and rarely do we much use cyclophosphamide anymore, but those drugs are next in line. Next slide. They all have the potential side effects. I wish we had greater time to talk about them, but they are, again, when monitored and used appropriately, they are wonderful drugs. But the key is, one, making sure they are monitored and used appropriately. Anti-inflammatory agents, we always have to worry about stomach ulcers, glucocorticoid or steroids. We have to worry about the myriad of toxicities that can occur with that drug, including weight gain, high blood pressure, risk of cataracts, etc. With the hydroxychloroquine, we have to keep track of the eyes. It is recommended that patients get their eyes checked once every 6 months, but the incidence of the ocular toxicity is limited. And then a number of the other more serious toxicities noted in group 5 and 6, but monitoring and, again, making sure we stay compliant with the medicines, the risk of those toxicities down there is actually quite small. Next slide. Again, it's quite a treatable illness. People are often frustrated because it has, quote, no cure. Well, it doesn't, but that doesn't mean there's not good, effective therapy. And if we are early in the course and treat patients aggressively, patients' longevity in this day and time equals that of the general population if, in fact, we have the right diagnosis and appropriate therapy early in the course of the illness. Next slide. Now, this is something here called the Rheumatologist Creed. It's that when we get our finish our fellowship, we must fall on our knees in front of our particular attending physician, and we must recite this as they put the sword on our shoulders and say we can be a rheumatologist. All of what I just told you is absolutely false. Actually, I made this up just 2 days ago. But it does, in fact, tell us what rheumatologists are about. And that is, we always strive to make a diagnosis of any inflammatory and also non-inflammatory conditions, such as osteoarthritis. We also base everything we do based on scientific data. There is no such thing as, well, maybe this is something we want to use. We base the recommendations in our patients only on scientific data that has proven to be efficacious in this disease. We always seek remission. Unfortunately, we don't always get that, but it is always our objective. And then lastly, we want to preserve functional capacity, enhancing quality of life. One of the blessings that I have by being able to work in a institution such as advanced pain care is that we have at my disposal people with the expertise, as Dr. Michaud, our next speaker, and our other pain management doctors, who pick up where we as rheumatologists are not so good, and that is with enhancing quality of life. When inflammatory conditions affect joints and cause destruction of bone or cause deformities in joints and bones, our drugs do not provide them with the ability to maintain functional capacity. One of the great things by being in a medical practice that has the specialists in orthopedic, specialists in neurosurgery, specialists in pain management, is that we keep these patients mobile. We allow these patients to live a full and free and pain-free life by having access to specialists like our next guest. And so with that, I would like to turn this over thus to Dr. Michaud.
Thanks, Dr. Pegram. Really do appreciate that. Hi, guys. I'm Dr. Ryan Michaud. My last name's actually Michaud. It's French, but we Texanize it. We say Michaud, but I always say keep it simple. Just call me Dr. Ryan. So good to meet everyone. Again, it's a pleasure for us to have Dr. Pegram, rheumatology with incorporated advanced rheumatology with advanced pain care, and all the other different specialties that we have to kind of help our patients get functionally better. And as we say here at the Advanced Pain Care, the pain stops here. So Adriana, if we can start with the first slide, please. All right. And so again, with pain management, it's a multidisciplinary aspect that should be incorporated if we're wanting to get the best results, okay? Meaning that it's not just medication management, it's not just, physical therapy, it's not just, the behavioral health, to address the psychosocial aspect, but it's all of those incorporation. And then also with what we do of different targeted, interventional procedures, all to kind of help out for our patients dealing with chronic pain. Can we go to the next slide? Now, again, medication therapy, there's a lot of different medications we can use. And again, of course, about the pain meds. And again, yes, I do prescribe pain meds. And yes, of course, with current times, we're all dealing with the COVID crisis. But again, before that, it was the opioid crisis. And again, even after the COVID crisis, we'll be probably dealing again with the opioid crisis. Again, what that means is, again, because of how things were in the past, perhaps overzealous prescribing of pain meds or not paying attention of the pain meds being prescribed with interactions of other medications that cause sedation. There were, unfortunately, a lot of patients having some, accidental overdose and leading to death, which is very, sad. But again, I do prescribe pain meds, and again, I don't have a problem prescribing them. But again, as I say, and as I tell all my patients, when I first meet them, is that these pain meds, of course, they're going to help decrease the pain, improve your function, because I'm a firm believer that the less you move, the more stiff you're going to be, the more soft you're going to get. And so again, I am a believer of you know, moving and function and things of that nature. But again, these pain meds cannot be looked at as the sole management. Because again, as I say, they're only really just banding. They're not doing anything to treat things, you know, structurally or mechanically or things of that nature. And again, with lupus, as you know, Dr. Pegram has described, it's an autoimmune disorder. It's the autoimmune in its simplest form, kind of attacking and destroying the joints in different areas and different tissues and stuff. And so again, it's very important that, of course, if you do have lupus, that you are seeing a rheumatologist and on proper medications to help slow that down or halt that. Now, again, there's also different medications that we use, such as neuropathic agents. Neuropathic agents are the ones that help out with the burning, the pins and needle, the electrical. The neuropathic agents that we commonly use are like gabapentin, Lyrica, Topamax. Now, again, as I always kind of describe these, I always say that they work on sodium and calcium slow channel receptors. They kind of slow the excitation of these nerves that are firing. But again, just as with any other drug, they can have a little bit of side effects. Again, if we go too high too quickly on those medications, then a lot of times they can affect the big nerve, the brain, and that can cause grogginess and somnolence. We also do prescribe different topical agents, such as diclofenac, which is Voltaren. It's a topical NSAID. It works just where you apply it. The systemic absorption is very minimal. So again, it doesn't have that high of a risk as the oral NSAIDs, which are like ibuprofen, Aleve, Advil, which can be bad for your stomach and kidneys and, you know, potentially bad for your heart. And of course, we do also prescribe different adjunctive medications such as muscle relaxants or things of that nature. Can we go to the next slide? Now, again, I always say, anytime I have a new patient, I always say, hey, I'm going to refer you out to physical therapy, okay? And I know a lot of times you've been before, but again, I still need you to go so that way they can see what you're doing. They can assess that. They can also give you some additional teachings, but then also, you know, we can get, you know, of course, documentation of that to kind of build on. But again, the myofascial component is hugely important because again, you know, you can reach out, touch a hot stove, just within that split second, you're contracting away from that painful stimuli. The body's way of keeping things safe and protected is usually keeping it contracted and close to the body. Same thing can happen when you have a pain generator, such as in the neck or back. Those muscles will spasm. When those muscles spasm, there's impaired blood flow through the muscle. The actin and myosin kind of stay contracted. They form off little connectile tissues, forming little trigger points, little taunt bands. And those are, again, you know, nodular areas, taunt bands, trigger points. The only way to get that better, it's not by heat, it's not by massage, it's by treating the pain generator and then by light stretches and exercise. And again, physical therapy is also a great modality to help boost your own natural endorphins. If we can go to the next slide. And then, of course, as I mentioned, you know, behavioral health aspect is hugely important. Again, you know, without a positive outlook, you're not going to get a positive outcome, okay? Meaning that if someone has undiagnosed and untreated depression or anxiety, no matter what we do, until we treat those psychosocial aspects, the patients won't get functionally better. We can go to the next slide. And of course, you know, as I kind of talked about, we do different types of procedures, different steroid injections. And again, you know, steroids we inject into particular joints. We, again, help out for the inflammation and pain. But again, you know, whenever you hear the term arthritis, you and I, we commonly think of a painful joint. And again, that is what we've associated with. But guaranteed, we can take an x-ray of your body, my body too, Dr. Pegram's also. His might have a little bit more of arthritic joints that are not painful. But again, the thing is that your body does repair damage to the joint that can happen from trauma, from overuse, misuse, degeneration. And a lot of times it doesn't always have to end up in being a painful arthritic joint. The hyaline cartilage can be replaced with fibrillary cartilage. And a lot of times, you know, with muscle strengthening around that area, we can help progress into a non-painful, arthritic joint. There's also different injections, such as, you know, we inject, you know, the rooster comb or synovial fluid into the joints. There's lots of other different procedures that we do, but I just wanted to kind of keep it kind of broad. Some of the other procedures that we do, if we can go to the next slide, Adrian, are what we call radiofrequency ablation. We can actually target some of these little individual nerves that innervate these particular joints. And again, we can actually initially do a block to make sure that that is a pain area for you. And then later we can actually then ablate, or as we say in layman's terms, burn that nerve. Now, again, I wish it was permanent, but the pesky little peripheral nerves do tend to regenerate. Again, but it can help out for reducing pain in that area. Just depends for some patients, 50% or more for 6 months, 6 to 12 months. We can go to the next slide. Some of those different areas that we do blocks are some of the genicular nerves. Those the genicular nerves which innervate the top and medial portion of the knee. We can block those nerves. We can also burn those nerves. And again, this is a different modality to help our patients, in dealing with chronic pain. We can go to the next slide. There's also different particular nerves of the hip that we can actually block: femoral branch, and obturator branch, and then we can later ablate or burn those nerves. And again, that can also help out, reducing the pain of that particular area. Now, I do want to interject, of course, if you do have really bad arthritis of the knee or hip, of course, nowadays getting a total hip or total knee replacement, although the rehab after can be a little bit cumbersome, but again, a lot of times, especially with the hip, nowadays they can go through the anterior approach. You're walking later that day, the hip pain is gone, it's no longer a factor in your life. So again, if we can go to the next slide also. We also do what we call a suprascapular block, where we can actually block the suprascapular nerve. The suprascapular nerve innervates about 60% of the shoulder. Again, that's another option that we can utilize, helping out our patients dealing with shoulder pain. We can go to the next slide. And then, of course, we also do what we call ablations of the little nerves that innervate these little joints in the neck and back. What we call the cervical medial branches, or here as shown, the lumbar medial branches that come off of the spinal nerve. And that can help out for axial, neck, and back pain. We can go to the next one. There's also other procedures that we do, such as if people do have compression fractures of their vertebral body. These can happen from osteoporosis. They can happen from trauma fall. Again, for some reason, you do get a fracture of your body, of the vertebral body of the spine. The old way of treating that was, hey, here's a brace. Let's increase your calcium, vitamin D3, give you some pain meds. The new treatment now is where we can actually put a needle, a trocar, right into that vertebral body. We can actually put a little balloon to re-expand it, to regain some of that height loss. And then we put some bone matrix cement into there, which actually kills off the free nerve endings, solidifies that area, and the pain is gone. If we can go to the next slide. And there's also other procedures such as what we call Vertflex, where we can actually minimally invasive kind of help for patients with spinal stenosis or other things. Spinal stenosis is pinching on the spinal cord. If we can go to the next slide. There's also pain pumps that we put in for patients where we actually deliver the medicine right to the spinal cord. Therefore, there's less systemic side effects. The medications are working right on spinal receptors. So we can go to the next slide. And then, of course, one of the things that we're known for is also our spinal cord stimulators. Spinal cord stimulators are a device that we place in the epidural space. These particular leads, I always use the example, it's like a labor epidural that pregnant women get that they can't wait to get when they're going into the hospital for delivery. But again, instead of medication now, these actually use the electrical field to help block the pain impulses from coming in and going to the brain. When they work very well. 90% of the patients that we do trials on get 50% on up to 100% of pain relief. And again, it just kind of varies. But again, these are some of the different modalities that we can offer here at Advanced Pain Therapy to kind of help you out and associated with lupus or any other chronic pain conditions. And then at this time, I'd like to open it up for general discussion or questions. Dr. Pegram's okay, and then we can go from there.
Yeah, so if anyone has any questions, you can put it in the Q&A or the chat box. I think we do have some in the Q&A. We have one that is, how important is it to have a definite diagnosis of lupus?
The diagnosis is the key because, as I mentioned, there are a lot of disease processes that mimic systemic lupus, and there are also a lot of patients who make anti-nuclear antibody who do not have a diagnosis of lupus. And so you don't want to place patients on therapy that may be inappropriate because your diagnosis is wrong. So it's important that you have a specific diagnosis so that you can tailor the patient's therapy to that particular disease process. Here's a very simple example. Patients with rheumatoid arthritis often make anti-nuclear antibody, so-called lupus protein. Doesn't mean they have two diseases, no. It just means they also happen to make that particular antibody. But the clinical findings in rheumatoid arthritis are different than the clinical findings in lupus. And so if you in fact gave the patient the wrong diagnosis of lupus based on an ANA and failed to treat them with disease modifying therapy for rheumatoid, they may feel a little better, but they still end up with deformities of the joints, which we never want to see. So that diagnosis is paramount. It is the basis of everything that we do. A specific diagnosis leads to specific and more effective therapy.
Okay. And then, do spinal specific painkillers help with joint pain?
So I'd be more than happy to answer that. Again, you have actually opioid receptors throughout your body in different areas. It also kind of depends on how innervation of that particular joint is getting to the spinal cord, traveling up the pain pathway and getting to the brain. But yes, pain meds can help with joint pain. They can help out with joint pain at different levels of what I kind of described there. There's opioid receptors that can affect, different areas of there. So yes, pain meds can help with joint pain.
Okay. And then what is the best way to treat moderate to severe pain, burning of the hands?
I guess it depends on what it's due to. Obviously, if the burning is due to vascular disease in systemic lupus or other autoimmune diseases, medicines that improve blood flow, vasodilators, are often quite effective. If in fact it is due to a neuropathic problem, meaning a nerve issue, then the modalities that Dr. Michaud had just mentioned, which I'll let him elaborate on, may be the better modes of therapy.
Okay.
Yeah,
and what else?
Sorry, go ahead, Adrian.
I was just going to ask another question. Go ahead.
No, I was going to say, if someone does have neuropathic pain again is kind of classically kind of described as burning, pins and needles, electrical. Again, that's where we use these nerve drugs such as gabapentin, Lyrica, Topamax, but also we can use different little topical agents possibly to help out. And then there's also different injections that we could do to try to help calm down this spinal wind-up phenomenon. So.
Okay. What else can be added to my regimen since I'm on Plaquenil and Humira for psoriatic arthritis and other autoimmune diseases? What about Xeljanz?
Yes, that's a good question. The combination of the biologic with hydroxychloroquine is a good and safe combination, but sometimes patients don't necessarily respond to any one particular drug. The Humira is in a class of biologics called tumor necrosis factor, TNF agents, and they have proven themselves to be quite effective. We now know that every 5 minutes you see a new commercial about a new drug for psoriasis on the market, but they all are effective, but they often target different aspects of the inflammatory cascade. And so some people do better with one than another. One is you can increase the frequency of the Humira. You can push the dose from every 2 weeks up to every 10 days and subsequently to once a week. If that doesn't work, you can move to another biologic in a different class. Medicines such as Cosentyx, Taltz, Skyrizi, and also Tremfya, they all work at different parts or work on different parts of the inflammatory cascade, and some patient may have a better response with one than another. JAK inhibitors such as Xeljanz and Rinvoq are the newest kids on the block. They are also very powerful, and they have also proven themselves efficacious in patients who are refractory to some of these other agents such as Humira. So it's good to have more options. But yes, drugs such as Xeljanz may be a reasonable alternative.
And then what could happen if you don't take medicine for lupus?
Well, unfortunately, lupus can be a fatal disease, and it is also a gradually progressive disease. And so the key is, again, early treatment. The earlier we initiate therapy, the better the patient's prognosis. And so it is not a disease you don't want to have a patient on some mode of therapy. It does wax and wane. Patients may have mild disease for several years and have severe disease for several more years and then back to milder disease. So vigilance is important. It's not a disease where you tell your patient, well, see us if you need us. It's a disease where we have to follow patients over time. But maintaining contact with your rheumatologist, being compliant with your medications, early diagnosis and treatment of illness, the prognosis in that condition is actually very good.
And then what is the recovery for the Vertflex procedure?
I'll be more than happy to talk about that. The recovery time can vary. The Vertflex procedure, if some of the participants don't know, that is where we actually put a little spacer that actually will flip out, and it goes in between the spinous processes. It's a specific treatment to help out for spinal stenosis, pitching on the spinal cord, or foraminal stenosis, which is pitching on the spinal nerves. It can also help out for facet disease of that affected area. Now, again, when we actually do that procedure, it's a small little, maybe 1-inch incision. We then insert what we call the choker, which is a larger type of needle down, and then we then deploy the device. Normally, we say that, I would say to limit a little bit of activities for perhaps maybe a week or two until the device is completely kind of scarred into place. And then you can do normal activities. We had some patients there that are with a Vertflex jumping on trampolines and whatever else. The actual device can actually handle up to quite a bit of force. Now, again, some of the risks are, with this particular device, that if there's too much force and the patient's bone density isn't that great, then you can sometimes deal with issues where the spinal process can fracture. And again, those are just different, risks. But again, for more detail, of course, I'd say, hey, give us a call. We'll be more happy to see you and do a consultation.
The media keeps pushing the COVID vaccine, but is there any literature available that guarantees the vaccine is safe for lupus patients?
It's important to note that none of the patients who are the participants in these clinical trials before the vaccines became available were people with autoimmune conditions. So they weren't tested on those patients. The thought was there was concern that with the initiation of another foreign protein, a vaccine, a virus, or in this case, you don't get the true virus in the COVID vaccines, you're getting something called a spike protein. Would they initiate or stoke an already overactive immune system? That is always a concern, but it does not look like that has been a frequent occurrence in patients with autoimmune conditions, including systemic lupus. Two is that patients, if they are on immunosuppressant therapy, it also does not appear that the disease is more likely to, or pardon me, the vaccine is more likely to cause a problem, meaning longer periods of malaise and fever, et cetera, in patients on immunosuppressant drugs. So they should still avail themselves of the vaccine. What we also don't know is we thought that will patients get full efficacy, meaning since we are on medicines to suppress the immune system back to normal, you need an immune response to get a good effect from the vaccine. So will you get the 95% improvement, protection, pardon me, that is touted by companies such as Pfizer and Moderna, or will you get 91%, or will you get 89%? That's the part we don't know until that data becomes available, but some protection is better than none. In patients who have systemic lupus, who are not in the midst of severe flare, who are not on high doses, continuous high doses of glucocorticoids, prednisone, or other forms of steroids, definitely should get the vaccine.
Are there alternatives to steroid use for reducing inflammation for patients who would rather not take steroids?
Absolutely. We are always looking for drugs that we call steroid sparing. That includes simple things like non-steroidal anti-inflammatory agents in those patients who are appropriate candidates for those types of medicines. Also, some of the medicines I put down in the slide presentation that we call disease modifiers, methotrexate, azathioprine, also hydroxychloroquine. All of these drugs are designed to decrease the need for cortisone. Steroids or cortisone are only adjuncts to help out, decrease disease burden until we can move on to something else. But absolutely, there's lots of alternatives to high dose cortisone. And the one factor you can bet on when a doctor puts you on cortisone of any sort, his primary objective is to take you off.
And then a person is moving to a new city. Is there a way for them to find a pain management doctor who is board certified or trustworthy?
Well, I mean, we can always try to assist. We do have our own professional message boards that we can reach out, asking who our colleagues recommend in that area. Other, of course, avenues to look would be, of course, online. Again, I wish I had a better answer of, moving to a new city and who's good. So.
Okay.
I think you should just stay here and see the guys at Advanced Pain Care. That's what we think.
That's right. I agree. Yeah.
What caused protein in the urine test? Can we prevent it?
Yeah, protein in the urine is an indicator that there is something going on with the filtering mechanism of the kidney. So it's a sign that doctors look for to determine if there is any form of, there's various forms of disease activity in lupus in the kidney, but protein loss is one that tells us that there's something going on. The goal is to chase the inflammatory cells in the kidney out of the tubules and out of the filtering units so that that protein, which is needed for other bodily functions, stays in the bloodstream and is no longer seen in the urine. There are a number of modes of therapy for the treatment of proteinuria or loss of protein in the urine. It is something your doctor will follow as they proceed with appropriate therapy, and often we can make it go away. Sometimes there are small amounts of protein that remain, but as long as they're small and the trend is not upward, your doctor is generally satisfied. But high levels of protein that appear in the urine is not a good thing. And it tells your doctor they need to be more aggressive in the treatment of your kidney disease associated with your SLE.
And then what are your thoughts on medical marijuana to help with joint pain?
Let's see, I'll leave that to Dr. Michaud at the moment.
Well, there's lots of different thoughts of medical marijuana. Again, if you are seeking to see if that's helpful or not, I'll be honest, the actual studies that have been conducted scientifically, true scientific studies really have not shown it to be so helpful for chronic pain. Now, again, that being said, can it be helpful for some neuropathic pain, cancer pain, nausea and vomiting? Absolutely. But again, that's where, again, I would advise you have to see a neurologist that specifically prescribes medical marijuana. And again, for us, we don't, just because, again, as being a pain physician, I'm the most scrutinized physician out there just because of the pain meds I prescribe. So again, that's all I could really advise on that.
Okay, what if you have one doctor diagnose you with lupus, a second says you don't have it? Should they try a third doctor?
Well, it depends on the scenario. Remember, it is a disease that is often difficult. A diagnosis that's often difficult to make. And so I think you have to be patient and you have to be vigilant. We may see a patient who has symptoms that are very suggestive of systemic lupus, but the numbers, meaning the data and all of the necessary clinical findings to give us those 4 criteria are just not there. So I tell patients that although between doctor and patient, I think you do have an autoimmune rheumatic condition, but I don't want to write lupus on your chart because, again, we want to base everything that we do based on objective data. But if I wait, doesn't mean we don't follow the patient. If we wait and repeat this data down the line, that diagnosis may become definitive. Also, although it has nothing to do with medicine as far as improvement in health, realize that if you put lupus on a chart and the patient may not have that particular diagnosis, and God forbid they go and try to get new insurance, and we put that diagnosis there in error, it could be detrimental to the patient's ability to become insured. So it's important that give the physician some time, make sure that they are constantly following you. Just not having the diagnosis doesn't mean you can't be treated. And then as time goes by with diligence and appropriate therapy, appropriate diagnostic studies, that diagnosis can generally be made.
Why do physicians not offer good pain management measures? Should patients seek out a pain clinic?
Well, I'm not understanding the question. I guess they're saying, are they having issues with appropriate pain management? Again, if that's ever the case, of course, I always say you're more than welcome to get a consultation with us so we can discuss that with you. So I don't know how else to really answer that. So
I think Dr. Michaud is being too modest.
Yeah.
For guys like me who don't have the knowledge he does about the nuances of pain therapy, he's the guy I want them to go to. Just like I imagine that if there's something going on with the patient's kidney from a lupus standpoint, he would want me to see them. But
absolutely,
pain guys have the expertise. They have the expertise about how to use the drugs, how frequently to use them, how safe they are. So yes, I think they should go see a pain management specialist when they are having refractory pain that an internist or a subspecialist is not treating adequately.
Thanks, Dr. Pegram.
And then is there another medication to treat lupus if hydroxychloroquine is causing eye issues?
Absolutely. The thing about hydroxychloroquine, remember, it's a preventive drug. It is not for acute exacerbations of disease. And in of itself, it is not strong enough to attend to major internal organ aspects of lupus. It is a drug. I tell my patients with lupus, think of it as your lupus vitamin. You're going to take it every day because it's going to pay me some dividends down the road. It may not do much for you now, but it's going to help us down the road. It improves longevity. Patients with lupus on hydroxychloroquine live longer. But if they have ocular toxicity, it has to go. So there are other medicines that can be used with limited toxicity that may work quite just about as well. But are they as good as a preventive agent? That may not be the case.
Are there any natural remedies to help with lupus?
As I tell patients all the time, my obligation to you is to tell you what I know, and that there's not good data in the rheumatology literature that adding something to a diet, taking something out of the diet will alter the function of your immune system. So that doesn't work. But maintaining a good, healthy diet maintains your weight, decreases the stress loads on your joints, Also, it decreases your risk for internal organ abnormalities caused by hypertension and heart disease. So I think a good standard American diet, maintaining one's weight, limiting your salt, good hydration is as good as anything. And so adding a bunch of other supplements that supposedly attend to decreasing activity or increasing activity of the immune system is fraught with hazard and probably doesn't do much.
And then how long is too long to be on Plaquenil?
Well, there's not too long. Your patients with documented lupus without evidence of toxicity from the drug should be on it for life.
Okay. And then this person has high levels of alkaline phosphate in the blood for over 3 years. Should they be concerned?
Well, the alkaline phosphatase can be from bone. Pardon me. Let me wet my whistle here. It can occur from bone. It can also occur from liver. The small levels of elevated alkaline phosphatase may not mean anything. And we always in medicine look for trends. If it's stable at a slight elevation, nothing you need to do. If you see the elevations are going upward, you certainly want to attend to that and look for potential causes in either the bone or the liver. We also know that patients who have low levels of alkaline phosphatase can also have certain medical conditions, not very common, but they can occur. So always keep an eye on it, but look for trends.
And then can you talk more about Benlysta? Does it take the place of other SLE lupus medicines?
It can. It's only for moderately severe disease. It's probably in potency akin to the oral drug azathioprine or Imuran. It is a very safe drug. It is effective in decreasing some of the nuisance-like symptoms in lupus, mental fog, polyarticular joint discomfort, skin rashes, pleurisy or serositis, articular discomfort, swelling, pain, and stiffness of the joints. So it is a good drug. And it is a drug, though, that if you have severe involvement of the kidney, or you have severe involvement of the central nervous system, or severe involvement of major internal organs, Benlysta is not approved for that. But for moderately severe disease that has been refractory to oral medications, Benlysta is a very good drug.
Okay, and then what if a patient has pain and tingling in their hands and feet? How can that be treated?
Dr.
Well,
Michaud.
again, we would want to find out why. Is it small fiber peripheral neuropathy? Is it from, diabetic, peripheral neuropathy? Is it from carpal tunnel, tarsal tunnel syndrome, other different things that could cause that? And again, for us, then of course, it's the treatment for that, but then also the treatment to, again, treat the neuropathic pain. And again, that's where we would look at different neuropathic agents and also in conjunction with other medications can help out for that.
Okay. I think we're going to go ahead and end there. Thank you, Dr. Pegram and Dr. Michaud.
Yeah, please keep it simple. Call me Dr. Ryan. So good to meet you guys.
Thank you, Dr. Ryan.
Yes.
Everyone, thank you so much for being on today. We hope that you guys enjoyed it. And if you have any questions, please reach out to your local chapter and they can send you more information. So everyone, thank you so much and have a great night. Bye-bye.
Thank you. I appreciate it.
Bye, Dr. Pegram.
Bye-bye. See you, Ryan.